Hello everyone, my name is Brittany Swigert. I am a first-year graduate student in the Counseling Education Program here at East Carolina University, and today I'm going to show you my hypothetical treatment program that I have developed based on my research for anorexia nervosa patients, which is very near and dear to my heart as a subject because I also have my undergraduate bachelor's degree in nutrition, and anorexia nervosa, as well as several other eating disorders and feeding disorders, are very much related to nutrition as well as other medical healthcare related fields. So it's a very widely spread disorder and very important for lots of healthcare professionals to learn about and to be knowledgeable about, not just counselors. I began my research for my treatment program by first looking at the general needs for this population, and I began by looking at the DSM-5 model for anorexia nervosa, and I came across a couple different factors that I thought were very important for the course of treatment. First being what population we're targeting here, or looking at mostly. And as I expected, average age of onset for AN is 19 years of age, and that is, just onset. I mean, it could be that these patients had negative self-worth, body image issues well before that. So really looking at high school, college-age students primarily, and then also looking at what timeline we're talking about for this treatment program. And pretty much what I determined most is that it's just a long timeline. There was one 12-year study that really stood out, showing an improvement while the patient was in therapy, a decline in improvement the 2 years following therapy, and then continued improvement in years 3 through 12 during this case study. And that showed also, in addition to it being a long treatment plan, it also showed the need for counseling throughout that timeline, and that it might not be practical for every patient to just stop therapy. And if that's what they need in order to prevent relapse, then that's something to consider for each individual patient. Looking on to what the National Institute of Mental Health also said, they identified 3 components, particularly for counselors in treating AN, and the first thing was to restore individual to healthy body weight. That is something that will be started, especially if they are admitted to the hospital. That's their primary goal there, and then they will be released to us outpatient as counselors, and that is something that we will have to continue. Treating psychological barriers related to the disorder, and that's where we have to focus on the cognitive as well as the behavioral issues, and not just the behavioral issues, which I will talk about more a little bit as we talk about CBT. And continuing to the last point, we also need to help prevent relapse and reduce these behaviors. Again, focusing on cognitive and not just behavioral issues will help to hopefully prevent relapse to this great extent, and hopefully we can kind of provide that stability towards the end of that person's lifetime and continuing on. Long-term treatment was the first thing that I decided that this population could truly use by looking at the research that I did previously. As I said before, it is a chronic, often lifelong disorder. Patients often require years of counseling, and this kind of led me to think about what is most practical for these patients. Obviously, counseling, first of all, is not free, and it is time-consuming, and it is not, always practical for a patient to spend every other week or even every other month for the rest of their lives in counseling, a counseling session at least. So I was trying to think of ways to provide this long-term treatment that will facilitate this need for assistance outside of the counseling office. And I came across a lot of ideas in my research for technology, and I thought that incorporating technology of different kinds, which I, again, will talk about later, will provide a lot of benefits for these patients. The next thing that I came across in my needs assessment for this population was, for most patients with this specific eating disorder, is exposure and exposure therapy. A lot of patients are faced with food anxiety, and this is a big cognitive issue that could be controlled in a setting such as a counseling setting. And I did some research on exposure and response prevention, came across a few case studies on where they used it, and it seemed to me like a great addition to a patient's therapy to allow both the patient and the counselor to track this patient's improvement. And the third thing, and probably the most important need for this population that I came across, was the need for personalized treatment. Stereotypically, the basic form of treatment that these patients are given is cognitive behavior therapy. I saw that a lot in my research. But I also came across a few articles in the last year, actually, where they have been adding to CBT cognitive remediation therapy, which seems to me to be a great idea in individualizing each patient's treatment plan. That addition of CRT will allow to focus on their specific behaviors and their specific cognitive factors, such as their negative body image, self-worth, all of those types of things. And being able to target these issues allows the patient to kind of restructure how they view themselves. So I took this literature and this research that I did and put it all together and created my treatment program, beginning with the CBT with CRT, looking at how to incorporate CRT and CBT into this treatment program was the biggest benefit to long-term potential, especially as you can continue creating new goals for your patients, as well as focusing on what their cognitive beliefs are at that point in time. And you can continue on to change their behavior, which, as we already discovered, is more of a chronic problem and not something that can just be solved in a few sessions. So being able to do that is very important. In addition to that main source of therapy, going on to talk again about exposure therapy, specifically for patients really dealing with that food anxiety. And lastly, incorporating that technology, which I talked about first, would really help for long-term potential as well, because they would be able to use this technology whenever they need it. And my biggest idea for this was creating some kind of phone app. And again, this is for my hypothetical treatment program here, so I can make whatever I want. I think that having a app for AN patients would be great. They can use self-care activities on the app. They can do meditation activities. They can do whatever else they might want to do. If they want to track how they feel day to day, what kind of low points, what kind of triggers, exposures they came across each day, then they can go back and use also the information that they have collected on this app daily when they do see their counselor, and they can talk about their progress and talk about their bad days, and they can focus on making new goals from the help that this app could do. And also, this could potentially be used as kind of like a social network thing for different patients to kind of connect to each other and build each other up and kind of create that community. Just an idea for that too. If not, there are definitely other apps that can be used. There's tons of meditation apps, etc. that would be great outlets to use in addition to the normal therapeutic process. So evaluating this program is not obviously going to be a once and done type of format after you have your pre-evaluation, and considering it is a long-term format for this program, there will be multiple post-evaluations constantly updating on how the client is handling their disorder as it is chronic. And there are also a couple different ways that these evaluations will have to be done, because it could be up to the counselor, who may be the only person constantly or more frequently seeing these patients. They might not be going and seeing a medical professional very frequently if they're in remission. So it's kind of up to the counselor to pay attention not only to the psychological factors that are affecting them or not affecting them, hopefully, but it could be up to the counselor also to pay attention to, okay, has their weight clearly changed since the last time I saw them? Is there other symptoms related to relapse that I need to be looking out for, that I need to be paying attention to? It is very important that the counselor does not assume anything with these patients or necessarily believe everything that they just flat out say. It's very important to pay attention. So another variable there is what kind of patient it is that you're dealing with, whether they're full or partial remission. If they are full, then that's going to kind of change their treatment program, because it's not going to be quite as frequent or quite as involved. And with partial, if they are still having those fears of gaining weight, or if they're still having a distorted body image, etc., it is going to be more involved for the counselor, and their evaluations are going to be different, because they're going to be keeping track of how these feelings are affecting the patient, and if they are strong or if they're just kind of mild or what have you. But it's up to the counselor to evaluate those regularly. So there were a few possible issues that I saw with this treatment program. The first one primarily about the use of technology at all in any treatment program is an issue with privacy and the ethical considerations to take place, and making sure that we protect our clients' privacy and our patients' privacy. Also, the benefits of CRT and CBT are also the difficulties they're one and the same for using this type of therapy, and that is because the counselor has that much more work to do and that much more experimentation with each individual client. It's much different than if you were to just use a generalized treatment plan for each and every patient that walks in the door. If you're trying to make it more person-specific, that just means that, yes, maybe it may be more beneficial. Those cognitive beliefs are going to be targeted a lot more. Hopefully there's going to be a lot less opportunity for patients to relapse. But at the same time, you're giving a lot more work for the counselor to do, and that's timely and costly. So it's also something to think about. And additionally, from all the research that I did, it just kind of seemed like the length of treatment is just very uncertain. And this could be a problem because, well, first of all, it's not free to counsel, and which I think I already said, and this could cause trouble down the road for patients who maybe don't have insurance, maybe lose their insurance. If they aren't staying on that treatment path consistently for as long as they truly need to, that can cause a lot of issues, and it can also, again, cause more difficulties for the counselor in planning and preparation for each individual client. Figuring out budgetary suggestions were kind of difficult as well, considering, again, this is not a specified disorder just for counselors to have to deal with. Counselors will also be working with other medical and healthcare professionals such as dietitians, possibly even psychiatrists, psychologists. It's something to consider as both a medical and mental health issue. And insurance will surely come into play, but it's a matter of working with these other professionals to kind of figure out what needs to be covered and who's going to cover it. Additionally, for my idea for the phone app, because this is my hypothetical world and I can create a phone app if I would like to in my hypothetical program, I would definitely see a possibility for getting a grant to manufacture that application and kind of get some momentum building to create that app. And that would be great for any number of the fields that would be interested in anorexia. That could be counseling and psychology, or it could be nutrition, it could be medical field, whatever. It could be lots of places. So that, I think, would be very beneficial and would probably cover any of the costs for creating that important piece of this program. Promotion is another topic that can kind of go a couple different ways. First of all, it's kind of tricky with an issue that's also a medical issue, because a lot of counseling patients that I'll have are being referred to a counselor from a medical professional, because a lot of the time, especially if they're hospitalized, they are being sent to a counselor as an outpatient, and they, it's kind of up for me as a counseling professional to kind of put myself out there, promote myself basically in my practice wherever I might work, to get these patients, but they're not necessarily just out in the community. But there is a lot to be said about prevention with this program, and especially with cognitive remediation therapy, using those ideas of those cognitive irrational beliefs that a lot of these patients have, and they have them before they are diagnosed with anorexia, and that is something that we can target in the designated population that we viewed earlier, that age of onset, 19 years. I mean, high school, college students, these would be the best population. This would be the best place to start with prevention and promoting these positive self-care habits, positive self-image, body image. All these things are important things to be promoting to these students. There was one particular study that showed only 33% of undergraduate women that participated in the study were considered to have normal eating habits. So these are out of hundreds and hundreds of undergraduate women who don't necessarily have eating disorders, and yet only 33% were considered to have normal eating habits. And that is kind of shocking, and it shows a lot about the fine line between just abnormal eating habits and having an eating disorder. And it is kind of up to us to prevent that line from being crossed, for sure. So thank you all for listening and watching this presentation. Here are some of the pieces of literature that I used to create this presentation, and there's a lot of great websites on here too, and other journals that talk a lot more about eating disorders in general and also anorexia. And it's very important for professionals across all these different fields that I've mentioned in the previous slides of this presentation to truly know the symptoms, risk factors for eating disorders and for anorexia. It's not just up to counselors, or it's not just up to medical professionals. We all kind of have to work together and really learn more about this population and how to truly help them. Thank you.